Hi, my name is Pete Sloan. I'd like to spend some time today updating you on the current state of affairs regarding the pathophysiology and management of acute respiratory distress syndrome. Before getting started, I'd like to let you know a little bit about myself. I have been a practicing pulmonary and critical care physician for almost 30 years on the teaching faculty at MedStar Health and Johns Hopkins. I serve as Chief of Pulmonary Medicine at MedStar's Good Samaritan and Union Memorial Hospitals, and am a founding partner of Pulmonary and Critical Care Associates of Baltimore, one of the United States' largest pulmonary, critical care, and sleep medicine practices. I outline my training, faculty, and administrative experiences and teaching awards here. I have a long-standing interest in ARDS. In the 1980s and 90s, I had been awarded an NIH fellowship in ARDS research and had several publications on ARDS regarding endothelial function, the role of neutrophil and role of TNF in ARDS, along with a large multi-center observational trial of 153 patients I published in ARRD, which is now the Blue Journal. I was fortunate to be a site investigator for the ARDS network between 2005 and 2012. Our site participated in the ALTA, Eden, Omega, and SAILS trials. I appreciate your joining me today. Your learners' objectives today are to describe clinical, radiographic, pathologic, and physiologic characteristics of ARDS, recognize types of ventilator-induced lung injury or VILI, apply ventilator strategies to minimize VILI, and to understand therapeutic options for advanced therapy for patients with severe ARDS. Let me start with a case report. A 22-year-old female with major depression came to our emergency room back in 2012. She was deeply attended and had left a suicide note. We suspected aspiration as her PO2 was 66 on room air, and she had some early infiltrates on her admission chest x-ray. She was intubated because of the aspiration and airway protection reasons. She developed progressive refractory hypoxemic respiratory failure with desaturations as low as 60% with agitation. She was placed on conventional ventilation, assist control with volume control breaths, a set rate of 16, FiO2 of 1, PEEP of 10, Tidal volume of 500, which was about 9 cc's per kilogram of predicted body weight. An ABG showed 7.37 pH, PCO2 of 43, and a PO2 on 100% FiO2, giving a PF ratio of 48 and a saturation of only 75%. Peak airway pressures after setting up the ventilator with conventional ventilation were 40 to 50 centimeters of water. What stands out about this case in my mind, beyond the obligatory good outcome in a case that I selected for this presentation, is that this was one of my earlier cases of severe ARDS that I managed with the help of lessons learned from the ARDS network. So this case was 2002, and about 18 months before that case, or maybe 2 years before the case, was the Sentinel landmark New England Journal publication from ARDS network showing the beneficial effects of ventilation with lower tidal volumes compared with conventional volumes, also controlling airway pressures. So in this case, we did use ventilator strategies to protect this patient's lungs, such as open lung ventilation. We used APRV with permissive hypercapnia, bilevel ventilation with a short expiratory time. At that time, I thought that 0.8 seconds was short, but we've since learned that we can go shorter. We were able to wean FiO2 down with the help of these ventilator strategies. We went for a low returned volume of 350 cc's, which was just over 6 cc's per kilogram predicted body weight. We measured auto-PEEP at 4, so our total system PEEP was 14. Our peak airway pressures were controlled no higher than 32, where on volume control they were in the 40s, and our static lung compliance was kept under 30. Now, all of these concepts we're going to get to as I go on with the talk, but I just wanted to show you that in the early 2000s, we were all moving towards lung protective strategy. So her ABG with these maneuvers on the second hospital day was 7.28 pH, PCO2 elevated at 65, PO2 of 96 on an FiO2 of 0.4. So the PO2 to FiO2 ratio, which is just dividing 96 divided by 0.4, was 213. Compare that to the ABG from the day before that I showed you already. Two big differences. Oxygenation is obviously a lot better. PO2 is up, FiO2 is down. PF ratio is markedly improved at 213. But the other difference is on the second day's ABG, when we had better arterial gas, we had an elevated carbon dioxide level at 65, which is your first demonstration in this talk of a permissive hypercapnia strategy. To be clear, there was a low pH, in this case 7.28, already some compensation, bicarb up to 29. Most of that compensation is related to the buffering system. By 24 hours, I think we were getting a little bit of help from the kidneys, but nonetheless, she tolerated the pH of 7.28 well, and we needed to keep the PCO2 elevated to achieve our goals of ventilation, which we will be discussing. So this is our patient's CT chest on day 11. You can see bilateral airspace disease, the heart's in the middle, dependent consolidation, which probably is not pneumonia. It's, as you'll see, just the weight of the consolidated lung on itself. Small effusions, which are the darker areas here. It's not a prominent feature of ARDS. However, atelectasis causes a negative intrapleural pressure and can draw fluid into the pleural space. Very typical basilar slices through CT. Even in this slice, you can appreciate some relatively skip areas of lung somewhat less affected. So another hallmark of ARDS that you can see on the CT is the disease is inhomogeneous. Consolidated lung, healthier lung, less consolidated lung, typically in the non-dependent position. So this is her chest x-ray on day 25. By now she has a tracheostomy, and I'm not showing you all the x-rays, but there's already clearing. Her lungs were literally whited out, so you can see some aerated lung coming back on the right, but this does meet the radiographic definition of ARDS, bilateral airspace disease in the absence of congestive heart failure. So as I mentioned, all stories placed into conferences like this have good outcomes. I saw her in the office about 10 months later. She still had bouts of depression, but no further suicide attempts. She was back to her regular activities with no pulmonary symptoms. Her examination was fine, and her PFTs were interesting. She had normal flow ratio at 93%, actually very good. Her FVC was in the normal range, but her total lung capacity at 83% was in the low normal range. She had a slightly reduced diffusion capacity at 71%, which corrects towards the normal range when accounting for her slightly small lungs. These lung functions are sort of borderline, but they demonstrate probable borderline restriction and a mild diffusion capacity. And what I think happened with this young lady is that she wound up with a little bit of permanent lung changes from the ARDS. But fortunately, we know from our regular pulmonary practice that patients can function normally with borderline restriction and a mildly low diffusion capacity. And that's because the lungs have plenty of reserve to function with only 84% or 71% diffusion capacity. So in July of 2003, which is about 9 months after she had ARDS, her x-ray was just about back to normal. Perhaps there's a very mild retrocardiac interstitial pattern here, but it's hard to recognize. So acute respiratory distress syndrome is a syndrome of acute and persistent lung inflammation with increased vascular permeability. It's characterized by three clinical features. These were described recently and are referred to as the Berlin definition. Widespread bilateral radiographic infiltrates like I just showed you. A P to F ratio under 300, further broken down to severe when the PF is under 100, moderate when it's between 100 and 200, and mild when it's between 200 and 300, along with absence of CHF clinically, or if there's a pulmonary artery pressure determination, a wedge pressure of 18 or less. Previously, ARDS was the subgroup of acute lung injury with PF under 200. Those that would currently be classified as mild ARDS would have been called ALI without ARDS. They had an ARDS picture, PF ratios 200 to 300, so we actually split them out as acute lung injury. But that's not in play anymore, so to be clear, we've dropped the term acute lung injury and we're sticking to ARDS with the previous ALI now in the mild ARDS group. ARDS is associated with alveolar collapse primarily in dependent regions of the lung. This results in intrapulmonary venous admixture of blood and severe arterial hypoxemia. This is the same patient I showed you just to remind you that there's a dependent predilection for the changes. ARDS predisposing conditions can be broken into two groups. First, systemic processes that don't start in the lung, but the systemic inflammation mediated by cytokines and inflammatory mediators in cells causes indirect lung injury. The most common systemic process associated with ARDS is no doubt sepsis, but other systemic inflammatory processes such as blood transfusions, which can cause a syndrome called TRALI, transfusion-related acute lung injury, multiple trauma, going on cardiopulmonary bypass where you're exposed to the membrane and your white blood cells could be activated, and also pancreatitis, which is associated with systemic inflammatory response syndrome. These are the kinds of systemic processes. Now, there are local processes that can directly injure the lung, whether it's pneumonia, pulmonary contusion, pneumonitis, fat embolism, amniotic fluid embolism, or near drowning. There are others. In the pneumonia group, any kind of pneumonia, but the two types of pneumonia that are really on our mind now was in 2009, the H1N1 pandemic had a predilection for causing severe ARDS-related viral pneumonia. Many of these patients were on high levels of ventilatory support. We had a network trial going on in 2009, and our network investigators reported our younger patients who were otherwise single system failure but healthy did very well with advanced support, including ECMO. If we can bridge them through the worst of it with ECMO, they were survivable. 2019 introduction of COVID-19 world pandemic. We're seeing obviously a lot of respiratory failure and ARDS in this group. As you'll see, ARDS is somewhat different than traditional ARDS, especially lung mechanics. The lungs seem to have a better compliance. Their clinical course is actually, in some cases, much more fulminant, and you'll see that we do need to act more rapidly to intervene. Patients can go downhill in a hurry with the pneumonia related to COVID-19 SARS-CoV-2 epidemic from coronavirus. The pathogenesis of ARDS involves diffuse inflammatory processes involving both lungs. There's systemic activation of circulating neutrophils. The neutrophils express internal antigens called intracellular adhesion molecules, or ICAMs, and those molecules bind to endothelial leukocyte adhesion molecules expressed by the endothelium of the microvasculature. There's release of proteolytic enzymes and toxygen-oxygen radicals from neutrophils. Although the neutrophil is a main mediator of lung injury and systemic inflammation in ARDS, it is not the only. There are models of ARDS in knockout rats that have no neutrophils that you can still incite ARDS. Because of all of the microvascular injury, there's leaky capillary syndrome and fibrin deposition. The inflammatory and thrombotic pathways are activated, so there's microvasculature thrombosis. From a pathophysiologic point of view, ARDS is primarily a disease of increased capillary permeability. So, no good discussion of movement of fluid from the vascular space to the interstitial space should take place without reviewing frank Starling forces. The net movement of fluid from the vascular space to the interstitial space is termed flux, denoted by Q in this equation. In healthy lungs, there is typically a low level of net movement of fluid into the interstitium, with the interstitium kept dry by normal lymphatic drainage. In a simplistic model, we recognize that the flux is proportionate to the hydrostatic pressure gradient. That is, the difference between the hydrostatic pressure in the microvascular versus the surrounding perimicrovascular space. In CHF, it is an elevation of the microvascular pressure that increases flux of fluid into the interstitium and ultimately into the air spaces in the case of pulmonary edema. ARDS, by definition, has normal hydrostatic pressure gradient as significant CHF excludes the diagnosis of ARDS. The physiologic abnormality in ARDS is an elevation of the proportionality constant, K, which is a direct measure of capillary permeability. To complete the equation, we must recognize that there is an opposing oncotic pressure gradient between the microvascular and the perivascular space, as indicated by the minus sign in this equation. In this case, elevation of the vascular oncotic pressure favors reduction of the net flux and vice versa. Although not a central concept to understanding ARDS, there's no doubt that a low serum oncotic pressure, such as that seen in hypoalbuminemia associated with either malnutrition or severe sepsis, contributes to net movement of fluid into the lung space. ARDS occurs in up to 4 distinct but overlapping pathophysiologic states. In the first 2 or 3 days, there is an increased permeability without much inflammation, causing a flux of fluid into the lungs and non-cardiogenic pulmonary edema, indicated by the red curve on this graph. Within 1 or 2 days of onset, the hyaline membrane phase starts with deposition, of hyaline membranes, the pathologic hallmark of ARDS. Following behind hyaline membrane deposition is an inflammatory response, shown in green, to the lungs, manifesting as an influx of activated neutrophils and mononuclear cells, which are activated by signaling from cytokines, including interleukins and tumor necrosis factor. In most patients with ARDS, there is at least a small degree of interstitial fibrosis caused by late fibroblast proliferation, but after recovery, the patient is usually returned to normal health, even though, as you saw in our patient, there could be some mild, subtle physiologic defects detected by PFTs, such as a low diffusion capacity or mild restriction. Up to 10% of our ARDS survivors have clinically significant permanent pulmonary scarring. The interstitial fibrosis phase is the last phase shown in black here. This slide represents the transition of normal lung through stages of progressive ARDS. In the normal lung, shown here, the alveolar walls are thin and lined with type 1 epithelial cells and type 2 pneumocytes, shown in the blue arrow right over here. We now see the changes in the first several days of ARDS. The pink arrow is pointing to a classic hyaline membrane, which stains pink on a hematoxylin and eosin stain. Hyaline membranes consist of a mixture of proteinaceous exudate, surfactant from type 2 pneumocytes, and cellular debris. In addition, there is mild thickening of the walls of the alveoli already with an influx of a few inflammatory cells, such as neutrophils, which stain blue. In the fibroproliferative phase, there is an influx of more chronic cells, such as lymphocytes and monocytes, fibroblast proliferation with the beginning of fibrosis, type 2 pneumocyte hyperplasia, and thrombin formation in the pulmonary capillary bed. The CT findings in ARDS patients with COVID-19 as the etiology during the 2019-2020 pandemic is somewhat different than what we had seen in prior ARDS patients like the case I presented earlier. The hallmark of COVID-19 ARDS CT findings is areas of relatively homogeneous ground glass densities surrounded by skip areas and a relative sparing of the dense consolidated findings that we have seen in the more typical ARDS pattern like I showed you. This CT of a patient from the epicenter of the initial outbreak in Wuhan, China demonstrates these findings nicely. I'd next like to discuss several types of ventilator-induced lung injury or VILI. The first type of VILI is called Volutrauma. Volutrauma is caused by damage to the lung epithelium by stretch of the lung at high lung volumes. Stretch also incites inflammatory reaction in the lungs. It's borne out in animal models. Large tidal volumes are independent predictors of lung injury, and it's supported in clinical practice and trials such as the ARDS Network's ALTA trial, which we'll go over shortly. Second type of ventilator-induced lung injury that gets a little bit less press is what we refer to as Atelectrauma. Atelectrauma is damage to the lung epithelium by cyclical collapse of the lung at low lung volumes. We know that repetitive collapse to very low lung volumes, followed by reinflation with each respiratory cycle, leads to shearing forces which damages the epithelium and parenchyma of the lung. We can minimize atelectrauma by adding significant PEEP, usually 8 to 10, but sometimes much higher, to help splint the lungs open, or it can be mitigated with ZEEP or zero PEEP, provided we use very short expiratory times, which are usually well under 0.8 seconds. Short expirations do not allow the alveoli time to equilibrate with the peak airway pressure, the proximal airway pressure. Most common mode we use for this is airway pressure release ventilation, which creates auto-PEEP. From the point of view of the alveoli, the PEEP is never broken because auto-PEEP is the same as extrinsically applied PEEP at the alveolar level. The next type of ventilator-induced lung injury is barotrauma, the type of injury that most people are quite familiar with. This includes pneumothorax, pneumomediastinum. Pneumomediastinum is usually harmless, but it's a harbinger of pneumothorax. So if you see pneumomediastinum, you might be ready to get a pneumothorax, or you may already have a pneumothorax that's not showing up easily on an X-ray. Subcutaneous emphysema, usually harmless, but can be a big clinical challenge. And biggest problem I have with bad subcutaneous emphysema is it's very hard to read the same chest X-ray for a pneumothorax because of the overlying crazy densities that we see from the sub-Q air. Pulmonary interstitial emphysema is an interesting phenomenon. We saw that in our series of 153 patients. Near end of life, air tracks into the interstitial space, causing lucency throughout the lungs. So it's common right before someone dies from respiratory failure with ARDS, their lungs actually get a little bit blacker as if they're starting to clear, but they don't improve clinically. The blackening of the lung is extra air in the lungs. The risk of barotrauma really relates to the mean and the peak airway pressure. We used to think it related to PEEP. When we raised the PEEP, we did see a lot of pneumothoraces, but that was because in the 1980s and 1990s, we would raise the PEEP up to 15 and allow the peak airway pressure to go up to 50 or 60. We're pretty confident that we can raise the PEEP up to 10 or 20 as long as we control the mean and the peak airway pressures, especially the peak pressure and the plateau, to keep them reasonable. I'll go over some guidelines for that later. Then the risk of pneumothorax is not too high. The final type of ventilator-induced lung injury I'd like to discuss is oxygen toxicity. Oxygen toxicity is caused by free radical damage to the lungs from the high FiO2. Damage to the lungs occurs within 1 day of high FiO2, and is dose dependent. The higher the FiO2, the higher the amount of damage. We can avoid oxygen toxicity by setting a low PO2 and saturation target. The PO2 target recommended about 55 to 80 and saturation just 88 to 92%. We use PEEP, auto-PEEP, and proning to recruit alveolar units, thus decreasing shunt fraction and decreasing FiO2 requirements. I strongly recommend evidence-based strategies to protect your patient's lungs from ventilator-induced lung injury, starting with low tidal volume ventilation at 4 to 8 cc's per kilogram, limit peak area pressure to 30 or 35 centimeters of water, and plateau or static pressure to 30 centimeters of water, or to the last plateau on volume-controlled ventilation, achieving good tidal volumes, whichever is less. Keep PEEP at around 10 centimeters of water, but there's many reasons to titrate up or down that we'll discuss later. Use APRV if needed to increase mean area pressure and create auto-PEEP to raise total PEEP. And titrate FiO2 down to under 0.5 if at all possible to avoid oxygen-free radical toxicity. To achieve all of these goals, you may need to employ a permissive hypercapnia strategy, which is okay. Keep the pH over around 7.2 if possible. So I won't go into this, but there is something called the ARDS PEEP-FIO2 table. It actually shows which combinations of FiO2 and PEEP to use as you increment the oxygen requirements on the patient. The low PEEP table are for the milder cases, and the high PEEP table are for the moderate to severe ARDS patients. In 2006, Gattinoni published a very interesting paper in the New England Journal highlighting the heterogeneity of responsiveness of alveolar recruitment to the application of PEEP in ARDS population. These findings were most enlightening, with the principal findings shown on this slide. His experimental model involved placing patients with ARDS in a CT and obtaining images at low PEEP of 5 and after an alveolar recruitment maneuver, which typically is a very high PEEP, in this case 45 centimeters of water, for about 40 seconds. Panel B on the top left shows no real change in the CT at low and high PEEP. As you can see, at low PEEP of 5, this patient had dense consolidated changes here, which at 45 centimeters of water did not change significantly. On the other hand, in panel C is an example of a patient with a much higher percentage of potentially recruitable lung, so that at low PEEP there was a lot of consolidation, but at high PEEP of 45 there was plenty of recruitment. So he next sorted the patient into 4 quartiles based on the amount of potentially recruitable lung. In these graphs, potentially recruitable lung are indicated by shaded areas. So in the first quartile, this little shaded area right over here is potentially recruitable lungs. This quartile had the least, and as we move to the left, from left to right, the right group, the 4th quartile, was the quartile that had the most. Now you could see, by definition, at the high PEEP of 45, it all went away. By definition, we're calling anything that's potentially recruitable is the part that goes away at high PEEP. So in each quartile, the recruitable lung is in fact recruited, so there's no more potentially recruitable lung at 45 by definition. So there were 2 interesting findings. Patients with potentially recruitable lung have much less hyperinflation at high PEEP. So let me show you that. This is the group that had the most recruitable lung, and the amount of hyperinflated lung at high PEEP is the very top. You can hardly see that little graph. When you look to the left, you'll see that the patients that have the least amount of potentially recruitable lung, when we apply all the PEEP, it goes up into the area that's already aerated, and that causes hyperinflation. So, the pressure has to go somewhere. So if it can't go to opening up lung units, it gets transmitted to the lung that's already normally aerated, which is the white lung. So we'll see some movement towards normal aerated lung plus some hyperinflated lung. In this last group, you'll see the normal aerated lung really increased. If you see, there was very little normally aerated lung. With the high PEEP, there was plenty of much more aerated lung and very little hyperinflated lung. Finally, his other interesting finding was intuition would lead us to believe that patients with the most recruitable lung, that is in this fourth quartile, would do the best. The authors, and frankly I, were all surprised that the opposite was found. Quartile 4, the group with the most recruitable lung, had a much worse outcome. That was unexpected. The authors theorized that high degrees of potentially recruitable lung correlated with worsening lung inflammation, explaining worse outcome. Just like other things, just because you respond well to treatment doesn't mean you have a better prognosis. Let's turn our attention to lessons learned from the NIH's National Heart, Lung, and Blood Institute ARDS network. This network conducted randomized multi-center trials of ARDS therapies. There were two iterations of the network. The first iteration, which ran between 1996 and 2003, published a positive trial called ARMA, low versus high tidal volume, in 2000 in the New England Journal, showing the effectiveness of low tidal volumes, improving mortality 22% and shortening time on ventilator and time in the ICU. I'll go over that in a minute. Negative trials were very helpful, although didn't change therapy, but they showed ineffective treatment with anti-inflammatory agents such as ketoconazole, lisofilin, and late-phase corticosteroids, as well as high versus low PEEP therapy. ARDS Network 2 ran for 7 years between 2005 and 2012. The major positive trial showed that conservative fluid and hemodynamic management improved outcomes compared to standard of care liberal fluid. Negative trials included PA catheter trial, which I'll show you, and several interventions including nebulized albuterol, early versus delayed nutrition, omega-free fatty acids and antioxidants, and the SAILS trial. I'll go over these. One interesting thing to know about ARDS network design is several of the trials were combined with what was called Factorial design. For example, a lot of people don't know this, but the conservative fluid management and the PA catheter trial were performed simultaneously in the same 1,000 patients. I'll show you how a Factorial design works in a minute. So going over the low versus conventional tidal volume study in ARDS, there was debate and really equipoise at one point about whether to use low or high tidal volumes. Conventional tidal volumes did have somewhat better gas exchange, more likely to cause PCO2, but there was concern growing in the 1990s that the larger tidal volumes were causing lung injury. Lower tidal volumes, such as 6 cc's per kilogram PBW, were felt to possibly cause less overdistension, potentially worsened gas exchange, but may prevent ventilator-induced lung injury. So the real question at equipoise was whether it was worth the price of hypoventilating in lower tidal volumes to avoid overdistension and avoid ventilator-induced lung injury. This was the rationale for the ARMA trial. So the ARMA trial was published in the New England Journal in 2000. One of the lead for the Chesapeake Consortium, Roy Brower, who I worked with in Baltimore, was the author of this trial. The trial showed an improved outcome of mortality. These are the Kaplan-Meier curves. These are the patients up here with the low tidal volume survival curve. These are the ones with the conventional tidal volumes, and the bottom curves show people getting discharged. So if you were a low tidal volume, you were going home at this rate, and if you were the high tidal group, you were still in the hospital, assuming you were alive. So here are the outcomes, the main outcome variables. The death before discharge was about 9% less in an absolute, but relatively 22% reduction of mortality, p-value 0.007. Patients breathed without assistance at a higher frequency, 66% within 28 days. There were more ventilator-free days, 2 more ventilator-free days, similar amount of barotrauma. So the low tidal volumes really did help outcomes in a dramatic way. I mentioned that I would show you how Factorial design. I also had mentioned that the fluid and hemodynamic management trial were co-mingled in Factorial design. So in this Factorial design, 2 studies, both published in New England Journal, were done in the same population. So there was 500 patient in the conservative fluid management, which was the restrictive fluid, and 500 in the liberal arm. These were randomly assigned. Simultaneously, patients were randomly assigned to get a PA catheter and a CVC catheter. Now, so there were 4 possible assignments, but within the conservative group, half of the patients had the PA or the CVP, and the same with the liberal. So there was no bias for one group to have better catheters or not better catheters. And likewise, in the PA catheter group versus the CVC catheter group, the same percentage of patients had conservative versus liberal. So you do get to do 2 studies in 1,000. It's not a perfect solution. Why don't you just do 100 studies in the same 1,000 patients? There has to be some statistical corrections for Factorial design, because the power of the study has to be adjusted to account for trying to do 2 different studies in the same population. So the FACTT trial, which stands for Fluid and Catheter Treatment Trial, was the conservative fluid trial. There was 2 schools of thought. Use standard of care liberal fluid strategy to keep CVP and filling pressures high to favor kidney and other organ perfusion, even if it was potentially at the expense of the lung. Another option is the opposite. Try to keep the patient dry. Keep the CVP low, fluid low, and minimize fluid input. That favors dry lungs, potentially improves pulmonary outcomes, but at the risk of hurting kidneys and other end organs. So here's another options for therapy that the answer was not known. There was kind of an equipoise in our community. There were people that truly believed, don't worry about the lungs, keep the patients hydrated to keep the organs going. There are other proponents of keeping them dry. Because no one knew the best solution, this was a good indication to do a randomized trial with the ARDS network. So the strategy in the treatment group was to discontinue maintenance fluids, continue medications and nutritional support, even if it was fluid. Manage on electrolytes and blood products as usual. For shock, we sort of were instructed to hold off on fluid conservation. You would have to resuscitate people as normal with shock, even if it included fluid boluses. However, after shock resolved, we tried to get back on weaning back fluid once vasopressors were weaned off. We withheld diuretic therapy that was part of the fluid management strategy if someone was in renal failure. And there was an algorithm for not only restricting fluid, but giving diuretics to the fluid restricted group as much as safely can be given. And this was based on a combination of blood pressure and hemodynamics. So the first thing with all of these trials is called separation. Before you look at the results, did the therapy hurt or help the patient group? Did we really achieve what we wanted? So the answer in the fluid trial was yes. In the group that had standard of care liberal therapy, they were a net 6 or 7 liters positive by the end of the first week, where the conservative group was an even balance. And lest you think that we were giving these patients extra fluid, It turns out this fluid balance was typical of the control group of other ARDS trials. So this really did represent the current standard of care before we came in and manipulated. Again, we kept the ARDS network kept the fluid even by holding off on all unnecessary fluids and pushing diuretics to the limit of tolerance. And now we get to the outcome. Did we help the lungs, or did we hurt the patient by drying them out too much? This is going to be the principal outcomes of the study. So here is the Kaplan-Meier curve for survival. And in the conservative group, which is the group that had fluid restriction rather than liberal, there was a trend towards better survival. So we certainly weren't hurting anyone from a survival standpoint, but as you'll see, this did not quite reach statistical significance. But the getting off the ventilator part did very well. The patients that were in the conservative group got off the ventilator earlier and statistically more. So here are the statistics. The death rate at 60 days, here I showed you 60 days, was lower in the conservative group, but it did not reach statistical significance. Nonetheless, the main endpoints were not mortality. The main endpoints were ventilator-free days, 2.5 more days liberated from the ventilator, statistically significant, ICU-free days between days 1 and 7, about a half a day more out of the ICU, and 2.2 more days out of the ICU in the first 28 days. In case you haven't seen the concept of ventilator and ICU free days, one little caveat. If you die during the study, your remaining days are all assigned to the bad outcome. So if you die on day 15, the next 13 days are assigned to the ventilator and to being in the ICU. It's not like you get an advantage of having a patient die so that they're off the ventilator and out of the ICU. That doesn't count. In a nutshell, the organ dysfunction was not a big deal. If anything, there was a trend towards some worsening organ function in the liberal group compared to the conservative group. I'm not going to spend time going over that, but it wasn't a significant problem, especially renal failure, where everyone was concerned if you're conservative, you would precipitate renal failure. Look at this, practically the exact same rate of renal failure, whether you're conservative or liberal. So the next part of the FACTT trial, which was the one that was factorially designed, the patients that were in the fluid trial either got a PA catheter versus a CVP monitor, showed no difference in mortality or other principal endpoints, trend towards increased complications and worsened outcomes in the PA catheter group. Since the FACTT trial, Swan-Ganz catheters are rarely used in ARDS management. The trend towards decreasing use of Swan-Ganz catheters or PA catheters actually started before the FACTT trial, but the way I look at it, the FACTT trial was the last straw. Any residual use stopped after 2000 when these trials were published. So ARDSnet-2, I'll go over their studies briefly. That was a 7-year trial. As I mentioned, there's consortiums around the country. I think there was around 55 or 60 hospitals, but they were in groups. So I outlined the Chesapeake Consortium. It was hosted through Hopkins. Roy Brower was the consortium's principal investigator and the author of the ALTA trial with the low tidal volumes, University of Maryland, but we're proud to say that 3 MedStar hospitals joined the Chesapeake Consortium to help with enrollment. My hospital, Union, Franklin Square, and Washington Hospital Center. I was the principal investigator in the northern division of our system for Union and Franklin Square Hospital, and beyond good work, it was just a lot of fun to be part of such a great network of hospitals doing good work. So it was a very good experience on a personal note. So there were trials that were performed by ARDSnet-2 was the ALTA trial. We'll go over these. Albuterol versus placebo. Eden, early versus delayed enteral nutrition. Omega, using omega-3 fatty acids and antioxidants to help outcomes in ARDS. and the SAILS trial, statins as an anti-inflammatory drug in the acutely injured lung. So the ALTA trial stood for a prospective randomized multicenter trial of aerosolized albuterol versus placebo for the treatment of acute lung injury, ALTA. So does aerosolized albuterol help outcomes in ARDS? Well, why should they? Salmeterol, which is a long-acting beta agonist, had been shown to increase alveolar fluid clearance, decrease lung permeability, increase surfactant release, and reduce peak and plateau area pressures, as well as inflammation, and improve mucociliary clearance in ALI lung models in rats. The study was designed to enroll 1,000 patients, but the long story short, it was closed in 2008 because of futility stop boundary. Here's an animal picture of the clearing of alveolar fluid in the lab. So the end of that trial is we now know that as theoretically nice as albuterol and salmeterol sound, did not work in a human trial. The Eden trial leveraged the fact that there was truly a equipoise about fluid management in the community with sick critical patients. Here's a graph before Eden about caloric intake in the critically ill MICU population, nothing to do with ARDS. But what you'll see is on ICU days 1 to 30, each graph, each line in the graph is a single patient's calories. So this guy never got fed. This guy, they made an effort to feed, but they got him only up to 25%. Here's a guy that was aggressively fed. By day 3, he was at 100%, and then he was overfed. But the bottom line is there's all different reasons and a big smattering of how people are fed in the ICU. And the real controversy is we don't know if early feeding is good or bad, or we didn't know, especially in ARDS. So the early versus delayed enteral nutrition trial was designed to determine whether early feeding and pushing for early calorie intake and volume loading from the feedings was good or bad. So we know that enteral nutrition early in critical illness carries risk. Aspiration, volume overload, electrolyte imbalance. There's risk. But we also know if you don't feed people, there's risk of undernourishment, such as muscular atrophy and immunosuppression. So the study called Early Nutrition was to try to reach 100% target of the calorie requirements within 24 hours. The other group was Delayed Nutrition, where we waited for 6 days to get to the target, and for the first 6 days the patient was targeted at 25% for trophic feedings to keep the endothelium healthy and get some feeding in. We obviously don't want no substrate at the mucosa. This study was another one of the studies. It was Factorial designed with the Omega trial, so patients were double randomized. I'll be showing you the Omega trial in a minute. Long story short is first separation. The study was able within the first 6 days to separate the calorie intake between the full feeding and the trophic feeding and the percentage of feeds, same exact graph. The fluid balance did separate as expected. People with full feedings, because they were tube feedings, had a higher fluid balance than people with the trophic feedings. So the question is, which one's better? Here's your answer. No difference in survival or many other outcomes. So we still don't know what's better, but there's no good evidence from this trial that going one way or the other is best for any given patient. Now the Omega trial, which was the trial that was double randomized with the Eden trial, which we participated with, was the theory of using fatty acids, which are essentially fish oil, and antioxidants that contain vitamin E and the like to reduce systemic and lung inflammation in patients with ARDS. Now, as a background, there was already a product on the market called Oxepa that smelled like fish oil that was being used and promoted for improving outcomes in ARDS. So the definitive large-scale randomized trial had not been finished. There were some smaller trials, but what was desperately needed was a randomized trial to see if this stuff really worked or not. It was very good in theory. So patients were randomized to either receive the emulsion or a placebo emulsion twice a day. This was, as I mentioned, designed in a factorial fashion with Eden, so the patients were double randomized. And the outcome was disappointing, to say the least. Patients that received the fatty acids had less days off the ventilator, less ventilator-free days, higher rate of death that just about reached statistical significance, and less ventilator-free day, less ICU-free days. This is days not spent in the ICU. They only had 14 days not spent in the ICU compared to 16, as well as less days free of organ failure. So, in summary, bad, 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 bad. This trial had to be stopped because of a stop boundary for safety, and it was actually ultimately published as not only no effect on improving outcomes. Let me read you what they wrote. This is what was quoted. I copied this right from the study. This study suggests that twice daily enteral supplementation of N3 fatty acids, GLA, and antioxidants changed plasma levels of N3 fatty acids, but did not improve clinical outcomes or biomarkers of systemic inflammations in patients with ALI, and in fact may be harmful. The Kaplan-Meier curve is depressing, to say the least. We were on a trend towards harming patients. What's important about the study is that this product was on the market, and I've never heard of a patient taking Oxypa since this trial came out. So good became of this trial, of this negative trial. Now, those were the 4 ARDS-2 trials that I participated with. None of them were positive trials, but they did affect management in several ways. I want to go over a change of topic now, what everyone's been waiting for, especially with COVID-19 this year. How do we mechanically ventilate patients with ARDS? What are the special considerations? So we know that a conventional ventilation strategy with full-size tidal volumes targeting normoxemia and normocapnia in patients with ARDS will predictably lead to ventilator-induced lung injury, and that's bad. For that reason, we must readjust our ventilator strategy in ARDS patients. We target acceptable, not perfect, oxygen goals, as I mentioned, PO2 55 to 80 and saturations 88 to 92%. We utilize permissive hypercapnia strategies if needed to achieve ARDS network goals. We use PEEP or auto-PEEP or both to decrease FiO2 and decrease risk of oxygen toxicity. And in our moderate and severe ARDS patients, we use a square wave strategy with pressure control ventilation to help increase mean airway pressure and control peak airway pressure. We also, in our sicker patients, use inverse ratio ventilation where we start to hold I time greater than E time. And in the more extreme cases, we go beyond simply inverting the ratio to APRV, which creates a very extreme inverse ratio with very short expiratory times. This raises mean airway pressure and promotes alveolar recruitment, decreases shunt fraction for a better PF ratio, allowing for lower FiO2. So this is, in one slide, how do we manage ARDS patients? Now, another thing about the ventilator is PCO2. In conventional ventilation, when the PCO2 isn't where is too high, we just raise the rate up. In these ventilations, especially on APRV, our first strategy is to just let it be high if they can tolerate hypercapnia. That's permissive hypercapnia. Our second way to adjust CO2 lower, rather than raising the rate, is to try to raise the driving pressure, provided you're less than 30. Or 35, and provided the plateau pressure is less than around 28 to 30. So the third way and the last way we do it is we try to raise the ventilator rate, but for reasons I won't get into now, raising the ventilator rate's not great for our other goals. So we're going to go over these types of ventilator strategies. Let's start with IRV. IRV simply means T inspired is more than T expired. Inspiratory time exceeds expiratory time. This increases the intrinsic PEEP by allowing insufficient time for completion of exhalation so that there's residual end expiratory flow as opposed to allowing end expiratory flow to go to zero. This can be used with either volume or pressure cycled ventilation. It may be uncomfortable for the patient. Now I want to go over, in case you haven't thought about this, extrinsic versus auto-PEEP or intrinsic PEEP. So extrinsic PEEP is the PEEP that we apply externally to the proximal airway. All pressures that we mention are relative to atmospheric pressure, which in real life is extremely high, but we set it to zero as a frame of reference. Intrinsic PEEP, also known as auto-PEEP, is additional pressure remaining in the alveoli at end expiration above and beyond extrinsically applied PEEP. In order to have intrinsic PEEP, we must have active end expiratory flow above zero. Converse is also true. So the presence of end expiratory flow proves the presence of auto-PEEP, and the absence of end expiratory flow proves the absence of intrinsic PEEP. Total PEEP is, at the alveolar level, is the sum of intrinsic and extrinsic PEEP. I'd like to discuss the beneficial effects of PEEP. PEEP improves alveolar recruitment, prevents expiratory collapse of alveoli, reverses microatelectasis and even macroatelectasis, increases functional residual capacity, which is the volume in the lung at the end of an expiration. By recruiting more alveoli, we improve shunt fraction, that is, blood that previously was zipping by lung units without any contact with alveoli now has access to alveoli that are aerated. Gas exchange improves, and lung compliance improves. Now you might ask, how does lung compliance improve? So I will show you. So let's start with a healthy lung. A healthy lung is like a balloon. To get a certain pressure change, a certain volume change early on, you need a lot of pressure. The curve is flat. But once a balloon starts to inflate, it gets steep. You can get a nice volume change, delta V, with a very small pressure change. It's the steep part of the curve. You know from your experience blowing up a balloon is that doesn't go forever. Later on, at high lung volumes, to get the same volume change, let me just draw a little line right here, you would need a much larger pressure change here. So we normally healthy people tend to breathe at FRC, which is very close to this inflection point. Remember, the inflection point between concave up and concave down is the steepest part of a curve. That's actually, if you remember calculus, that's when the second derivative is zero. But in any event, the maximal slope of a curve is at the inflection point, because concave up is improving compliance, concave down is worsening compliance. So the changing point is best compliance. Okay, so now you know where a normal person stands on the curve. So there's actually two problems with ARDS that I'm going to show you. First, the entire curve is flat. That is to say, at any point on the curve, to get the same size breath in, we need very high pressures. In fact, this explains why we can't use normal tidal volumes. We have to use a low tidal volume to get a lower pressure. I'll just draw that for you. A low tidal volume allows a smaller pressure. The second problem is based on all those CAT scans. Before we put the patient on the ventilator, they have a lot of lung collapse. Their lungs are at very low lung volumes. So they're down on the curve down here where the lungs are extremely stiff. The slope is sort of, I'm going to draw the slope for you in this direction here. So when we pressurize the lungs with PEEP, we sort of scooch the patient up their curve, and we put them onto a more favorable part of their curve where the compliance is better. So we know that both atelectatic lungs and hyperinflated lungs, like an emphysema, are naturally stiffer because they're at the extremes of the pressure volume curve. So we like our COPD patients to decompress back to a non-hyperinflated states. They feel better. And we like our ARDS patients who are at the low end of this curve to scooch over to the right to the steeper part of the curve. Now, all good things with mechanical ventilation have deleterious effects, and PEEP is no exception. PEEP is pressurizing the chest, no different than a tension pneumothorax or cardiac tamponade, and can translate to the epicardial surface and depress cardiac performance, also decrease venous return to the right heart, and can cause barotrauma in theory, although we've learned that as long as you regulate the mean and peak airway pressure, the risk of PEEP directly causing barotrauma is minimal. Now, one other interesting thing is that, and it's a long story, but PEEP transmits much less efficiently to the heart in patients with stiff lungs from ARDS. I'm not going to get into that reasoning, but it sort of gives us some immunity. We use PEEPs 10 to 20, and we don't see a lot of shock from the PEEP. The opposite's true with COPD, where when you crank up the PEEP on COPD, you'll have massive amounts of auto-PEEP and transmission to the heart and predictably shock. It's actually very hard to use some of these strategies in patients with active bronchospasm and COPD. So let's talk about square wave or pressure control ventilation. So in this curve, the patient's kept at a high pressure that's regulated, that we raise the pressure to a goal for a certain amount of time, and then we drop the pressure. In this example, the high pressure is a little bit longer than the low pressure, so this is a pressure control ventilation with an inverse ratio. This is IRV. Now in this case, the flow has to go in to pressurize the lung, and then to maintain pressure, the flow goes down. And at the very end, when there's exhalation, the flow obviously has to go out in the negative direction, and then the flow tries to return to zero, but you could see because of the shorter expiratory time, the flow never reached zero. We know right over here, we know that there must be auto-PEEP. I said that before. If there is positive end expiratory flow, there must be auto-PEEP. Let's think about that logically. Something is driving the flow out of the lung. At the mouth, if the PEEP is 5, since there's outward flow, there must be a higher pressure in the alveoli pushing the flow out. What we know right in this part of the graph is there must be auto-PEEP. What we don't know is how much auto-PEEP there is, because we're measuring at the proximal airway, but the auto-PEEP is in the alveoli. We don't have an easy way to get to that. Although we actually do, we have something called an end expiratory breath hold or auto-PEEP maneuver, and I'm going to show it to you right here. We program the ventilator to close the system at end expiration to allow the pressure in the alveoli, which is higher than the proximal airway pressure, to equilibrate with the mouth. That way, right over here, we get a system pressure that reflects alveolar pressure because it's a closed system and all of the pressures are equilibrated. And here we have it. If this guy's PEEP was 5, that looks like around 4. His total alveolar pressure is 9. That's how we do an auto-PEEP maneuver. Next thing I want to show you is why we like square waves and why we like inverse ratio. I'm going to show you some examples. Here's a generic pressure curve from conventional ventilation. It's a slow rate, and the breath goes up just for a second to the high pressure and it comes down. It's not even at high the whole time. Lots of time at low, so that the peak pressure might be 30 and the PEEP might be 10, although the arithmetic average of those two numbers is 20. Just like a blood pressure, the mean pressure is actually closer to 10 because of the timing, more time at low than high, and also the shape of the curve. You're really not even at 30 much of the time. You're at 25, 20, 15, 10. So we have very much more of the time is at 10 or near 10. That means the mean pressure is 15. Now consider square wave ventilation with the same two pressures, 10 and 30. Here we are. So now we use the same two pressures, 10 and 30, but you could see right away, because it's a square wave and because it's inverted, the mean's going to definitely go up. And it would go up to 20 if it was 50-50, but because it's inverse ratio, in this example, I'm demonstrating that the pressure is 25, which is probably about right. It's kind of a weighted average of the pressure. From a calculus point of view, it's actually the area under the curve. That's the actual way we do a curve analysis for the average of a waveform. It's the area under the curve, the integral. 5. So let's talk the next step. Pressure control ventilation was uncomfortable because the patients were forced to keep the pressure curve on target. Then bilevel came along, which has several names. Some ventilations machines just call it APRV, but what we use is we use bilevel as the generic. Bilevel is breathing spontaneously at 2 levels of pressure. You breathe at high spontaneously. In this case, the spontaneous breaths are supported. And then when you're at low, if you choose to, you could take a breath, although if you keep the low time short, people tend not to take a breath during the release. So that's what bilevel is. It's important to note when someone's on bilevel, they are allowed to breathe spontaneously. So they have 2 types of breaths. Spontaneous breaths tend to be small. First of all, your lungs are completely filled at high pressure. So when you take a spontaneous breath, there's not a lot of room to put the breath in. The lungs are already at a higher pressure. So these tidal volumes could be 50 to 100 cc's. They're small breaths. The big breath you get on bilevel is called the release breath. When the pressure drops down to low and goes back up, a volume is released. That tends to be a higher volume. So there's 2 types of breaths. The difference between bilevel and pressure control is on bilevel, the patient's allowed to breathe spontaneously at high or at low. The final part of my talk are advanced therapies for severe ARDS. The list of these therapies I'll leave on for a few seconds and then we'll get right to it. I introduced the topic of airway pressure release ventilation earlier when we talked about bilevel, but let's get into more detail. APRV is a more extreme application of bilevel and inverse ratio ventilation. We use APRV for moderate to severe ARDS patients with PFs less than about 150 or 200. Contraindications to APRV include hemodynamic instability from RV dysfunction, chronic pulmonary hypertension, elevated intracranial pressure, BP fistula, and acute obstructive lung disease. I had mentioned that APRV mixes very poorly with obstructive lung disease. You can generate extremely high auto-PEEP levels, which will have hemodynamic significance. I want to show you how we recommend setting up a ventilator to APRV. Our hospital system has moved to the Mackay Servo U ventilators. There's different ways to set up each ventilator that are subtly different. In this brand of ventilator, there's no direct ventilator rate setting. We set the time high and the time low, and the rate is calculated. For example, if we set the time high at 3.4 seconds and the time low at 0.6 seconds, we know that each cycle is 4 seconds. Divide 4 into 60, and we know that we're at a rate of 15. The goal ultimately is to work the time high up and the time low down to get 90% of the time at time high. For example, 4.5 seconds at high and 0.5 seconds at low. That would be 90%. So initial ventilator settings beyond the rate, we want to set the high pressure to either the prior plateau pressure seen on the most recent ACV settings that used ARDS network tidal volumes, or 35, whichever is lowest. Let me give you an example. If a patient was moving off of volume control ventilation to APRV and their last tidal volume was 375 based on ARDS recommendations and the plateau was 25, we would set the PEEP high on 25. On the other hand, if the plateau was 40, then we would set the pressure to 35. So we do whichever is lowest. We set the PEEP low usually to 0. A lot of people might think that's a typographical error, but I'm going to explain in a little while why that on APRV PEEP low does not matter. And by making it 0, we have a higher driving pressure. We're not worrying about PEEP at the alveolar level because we're not allowing enough time for the auto-PEEP to equilibrate when we use very short expiratory times. So how about the time high? I used an example of 3.4 seconds, but that was just an example. We are recommending using 3 seconds if there's a low pH. That allows about 15, 16 breaths a minute. On the other hand, if the pH is acceptable 7.3, we can start with a higher T high, 4 to 4.5 seconds, which will get the rate around 11 or 12. Either way, we want to slowly increase the PEEP high towards about 4.5 seconds and try to get the T low to maybe go down from 0.6 even a little bit lower. I gave you an example that was a 90%. If we were able to get the time high to 4.5 and the time low to 0.5, we would be up to the 90% rule. Now, when we set time low, 0.6 is a good recommended starting point. We are not only looking at the time high versus time low, but we're actually looking at the end expiratory flow to PEF ratio and trying to target 75%. I have a graph in a minute to show you how that looks. I made a graph for you guys. So here's the graph. This is actually probably the most complicated graph I'll show you, but work your way through it. Here's someone that started at 3.5 of I time, 0.6 of PEEP low time, and the PEEP low is 0, which is ZEEP. We said that we really don't have to worry about PEEP when we're on APRV. What's happening is the flow goes in to get the pressure up to the target of 28, and then it comes down. It has to hit 0 before it comes out. When the flow comes out, there's a rush of outward flow to a maximum called peak expiratory flow, just like a peak flow maneuver with an asthma patient, and that's created by elastic recoil. Now, normally, if you allow the lungs several seconds, the flow would go to 0 and you would end your breath. But because expiratory time is so short, there's still quite a bit of end expiratory flow. In this case, more than half of the end expiratory flow is remaining. So let me actually show you some readouts here. So with respect to timing, which I have in red, in this example, time at high is 3.4, time at low is 0.6, the cycle time is 4 seconds, so the rate's 15. I showed you that already. Now the percentage of the time at high is 3.4 out of each 4-second cycle. It's 85%. It's not quite 90% target, but it's not bad. We are spending a large fraction of the time at high. Second of all, our PEEP high is 28 and our PEEP low is 0, and in most ARDS patients we would never keep the PEEP at 0, but the exception is in APRV. We know that there is a ton of auto-PEEP trapped in the lung at end expiration, and at these very short expiratory times, the alveoli are nowhere close to equilibrating with the pressure at the proximal airway. Finally, just to show you some numbers, if the peak expiratory flow is 60 and at end expiration it's 42, that's the flow rate coming out, then the ratio is 42 divided by 60 is 70%. And our target is around 75% is a typical target. Now you have to have flexibility. If someone starts to have a lot of auto-PEEP, hyperinflation, and hypotension and goes up on the pressors, you may have no choice but to lengthen expiratory time. That would allow expiratory flow to go lower, get you further from your 75% target, maybe 50%, in which case you may not have as good gas exchange, but at least you can get the patient off of the Levophed and out of shock. This is especially potentially dangerous if you have any obstructive lung disease trying for these types of values, as I mentioned before. Next strategy, permissive hypercapnia. Advantages of allowing PCO2s to be out of range high and a low pH is it allows us to reach our low tidal volume ventilation goals. It helps achieve peak airway pressure and plateau goal as well. Disadvantages are acidosis, of course, CNS dysfunction. Acidosis is a vasodilator, so there could be elevated intracranial pressure. Acidosis may promote muscle weakness. Slightly higher FiO2 requirement on the basis of the alveolar gas equation. Remember, as PCO2 rises in the alveoli, there's a reciprocal drop of PO2. Go back to your alveolar gas equation if you don't believe that. And hypercapnia and acidosis can depress respiratory drive. Of course, that's not an issue if your patient is paralyzed and sedated. Prone ventilation in ARDS. Next topic. So it's defined as delivery of mechanical ventilation while the patient is in prone position. That's obvious. It's not a mode of ventilation. That's not so obvious. I get the question, could we use prone ventilation on? Could we switch them to prone ventilation mode? The answer is no. We have to still pick a mode, but we can prone the patient while they're ventilating with a mode. Prone ventilation consistently improves oxygenation in ARDS. Mechanism of this improved oxygenation is an improved homogeneity of pleural pressure gradient, both ventrodorsally, that is front to back, and cephalocaudally, that's head to toe. It makes the heart dependent, takes the weight of the heart off of some of the lung. It reduces and relieves compression of usually dependent lung zones. Improved secretion, drainage, and mobilization. Improves ventilation and aerosol delivery, and it improves VQ matching and improves the shunt fraction. So there's lots of mechanisms. The important thing to know is it predictably improves oxygenation and helps get FiO2 down. Mortality in prone ventilation. For many years, we knew it helped oxygenation, but there was never a good large-scale study showing a mortality benefit. Until 2013, when Prosiva came out, proning in severe ARDS patients, 466 patients with severe ARDS, that is PF less than 150, were either prone for 16 hours or not. Mortality was insanely better, 16% versus 32% without more complications. They used 17-hour sessions. They got 4.5 sessions on average onto their patients, and they used ARDS network guidelines for the rest of the ventilator settings. They did not use proning device beds. They used standard ICU beds for both groups, which is good news, especially for the COVID-19 epidemic, when we'll be proning many, many more people than we have proning beds for. So I talked by teleconference with a physician from China who's the Critical Care Society director, and China's experience was prone early. I'll leave it at that, but that's now officially everyone's guidelines. In COVID-19, prone early. So the mortality in proning, here's the Kaplan-Meier curve. The top red is the good group that lived. The supine group had double mortality. Types of proning bed. If you are going to use a bed, you have a Rotoprone as a brand. Stryker made a bed called the Stryker model bed that rotisseries the patient versus manual prone. Here's a patient being manually prone. Manual proning has its own set of problems, but with training and planning, you can train nurses to do this. You do need to worry, just like when you're supine, you have pressure points, you have a different set of pressure points in prone position that are outlined here. They're all pretty obvious when you turn someone on their stomach. So there are contraindications to prone ventilation. I'm going to just read them. They're all important. Hemodynamic instability, unstable spine, open chest or abdomen, massive hemoptysis. Relative contraindications are pregnancy, renal replacement therapy, and cardiogenic shock. Other contraindications are tracheostomy, elevated ICP, bleeding, and fractures. Several relative contraindications, as you can see. I'll leave these up. Complications of proning ventilation are predictable. Crush injury, facial edema, nerve compression, dislodged ET tube, probably the most commonly quoted complication, pressure sores, ocular damage, and arrhythmias. So the procedure is 18 hours, 16 hours prone, 8 hours supine. This is our system's procedure. We go for deep sedation, rest -4, paralyze if necessary but not required. Take care of the eyes. Sedation vacation only when supine. And of course with paralytics reversed if they're on them. And ensure that you plan all of your procedures for supine hours. Nothing worse than interrupting proning to do a needed procedure. That's poor planning for the most part. You may continue to feed while prone. There's a checklist that resembles an airplane cockpit checklist that you have to run through before proning, making sure you have everyone and everything available when you do the proning maneuver, especially with respect to safety, and for manual proning, being ready for all the pressure points that you're going to bring into play. So we're going to talk about lung recruitment maneuvers. Lung recruitment maneuvers are brief applications of high PEEP to recruit areas of lung that are not contributing to gas exchange in order to decrease shunt fraction and increase oxygenation, thus decreasing FiO2. Maybe, but not necessarily should be, attempted in ARDS patients with PF less than 150 in the middle of the moderate severity range. So the maneuver goes as follows. You apply PEEP of 35 to 40 for 40 seconds, sometimes referred to as a 40-40 maneuver. And it's controversial whether this should be repeated. General recommendations is consider repeating it once or twice if there's transient, non-disdained improvement, but if there's sustained improvement, it's felt that multiple repeats will simply lead to alveolar overdistension. Usually we see benefit of oxygenation, but there's been no proven mortality benefit. I guess they haven't done the big scaled studies. That would be a very hard study to do, although it is possible to randomly assign people for recruitment maneuvers or not. There are reports of hypotension, desaturations, barotrauma, and even cardiac arrest during the maneuvers. So reminds me of adenosine. When you give the dose of 6 or 12 milligrams, you kind of hold your breath and see what happens, because it's kind of interesting the next 20 or 30 seconds to see what goes on. ECMO. Definitely can't get into it here, but there are really two basic types of extracorporeal membrane oxygenation, veno-veno and veno-arterial. Here's a setup of veno-veno, which only bypasses the lungs. In this case, blood's siphoned out of the femoral vein and returns through an oxygenator and pump back to the central circulation. You can also do veno-veno bypass through other sites such as the femoral veins. This is veno-arterial ECMO, which not only can bypass the lungs but bypasses the heart. It's like being on cardiopulmonary bypass. This is not only used for oxygenation and CO2 removal, but also to bypass the heart for circulatory support. Discussion of ECMO beyond a basic appreciation of options is well beyond this talk. So I want to actually talk about ECMO in general for ARDS in the setting of the current COVID-19 pandemic. So at our system, ECMO is available at our one center that does ECMO, subject to their surge and capacity. So just a general idea, they have 3 levels. When they have plenty of capacity, they'll run ECMO on their own patients and system referrals. If they're at moderate capacity, they're going to close referrals as their hospital gets busier, but they'll consider doing ECMO. The threshold does change a little bit. The age, for example, goes up in this medium capacity. And when they're on full surge, they're going to suspend ECMO for all patients. And that's because ECMO is time and labor intensive, and they'll simply not be able to service the community if they have a severe surge. Indications for ECMO for our system are failed traditional ARDS management, assuming you've done ARDSnet ventilator management, prone positioning, and even inhaled ibuprostanol, along with varying degrees of refractory hypoxemia from a PO2 of 50 for 3 hours, 80 for 6 hours, or persistent severe hypoxia for longer. There are numerous contraindications to ECMO, especially during the COVID-19 pandemic when resources are scarce. I'm going to leave these up for a few seconds when I'm done, but I'd like to show you the ones in reds, which are the ones to me are most striking. Obviously, a patient with a poor underlying functional status, it's not a good time to use resources when we have limited resources. Patients will need systemic anticoagulation, so that's a contraindication if they can't handle it. Irreversible organ failure, other things that are non-survivable, such as a high multiple system organ failure score, age more than 70, and then a big one I hadn't thought about, family that's not consenting to leave it up to the medical staff's decision to stop and withdraw ECMO will not be allowed. In other words, a family must consent to allow the physicians to make a decision as to when it's time to give up on ECMO because of failure to respond. So I'm going to leave the slide up for a second. You can go back to it if you need to get these contraindications. This is from MedStar's guidelines. I'd like to discuss other advanced rescue therapies for severe ARDS. First, neuromuscular blockade. This should be considered for all patients with refractory hypoxemia, uncontrolled dyssynchrony with the ventilator, increased metabolic production, increased worker breathing, or patient movement in spite sedation and analgesia that's interfering with oxygenation and lung mechanics. Inhaled epoprostenol, trade name Flolan, hasn't been routinely used in ARDS, but may improve oxygenation and secondary pulmonary hypertension. This has never been shown to have clear improvement in mortality, but can lower pulmonary hypertension and improve oxygenation with some side effects of hypotension and renal dysfunction. This medication is available in our hospital system for rescue therapy. Generally, you get consult from someone that's experienced with this to see if your patient's a good candidate. But our rule is you have to have failed ARDSnet management and prone positioning before starting epoprostenol, not just because we want to save it for desperate times, but we don't want to confound two interventions at once. It would be very hard to know what's going on if you did proning and epoprostenol together. You would never know which is helping the patient. High frequency ventilation has some theoretical advantages, but no proven benefit in adults with ARDS and is not recommended. One final word, there's a strategic national stockpile of ventilators we've all heard about. I just put the three pictures here. The LP10 has very low functionality and is probably not going to be very useful for ARDS ventilator, but I can envision putting our more routine patients on LP10 to free up other ventilators. So I'm going to give some summary slides. I'm not going to go into these in too much detail. These are all from MedStar's handout. Eric Kreiner and Akram Zakuk both produced a wonderful set of guidelines for our system, but they describe 3 levels of ARDS, green, yellow, and red as it gets more severe, and then the interventions from simple measures. In level 2, we start to get into APRV and the high PEEP table. In the middle of moderate at about a PF of 150, we're going for neuromuscular blockade, inhaled EPO, and proning. And then when we get well into the severe phase, we're adding in ECMO as a possibility if the patient qualifies and the resources available. This is oxygen, ventilation, and PEEP tables that I mentioned earlier. I thought I'd put it in my talk so you have access to these directly from my talk. Take a screenshot or whatever. This is the setting the ventilator for APRV that I went over. It's just in one nice table. In conclusion, acute lung injury is defined as bilateral infiltrates, hypoxia, and absence of CHF in a patient. ARDS is a more severe form of acute lung injury. Specific therapies are neither proven nor widely available for ARDS, therefore we're left with advanced supportive therapies. Supportive therapy is the mainstay of treatment. Strategies to protect a patient from ventilator-induced lung injury, whether Volutrauma, Barotrauma, Atelectrauma, or oxygen toxicity, are critical to successful outcomes. Low tidal volume, low pressure ventilation with a permissive hypercapnia strategy is recommended. Consider using APRV as patients get worse. Consider advanced therapies, prone first and early, especially with COVID-19, permissive hypercapnia, lung recruitment, ECMO, etc. Avoid unproven therapies except as an absolute last resort. And first and foremost, do no harm. In this context, do anything you can to prevent exacerbating the problem with ventilation-induced lung injury, which is really iatrogenic. I want to thank you for sticking with a rather long course to the end. I have more content available for free on my YouTube channel. Just enter Peter Sloan MD into the YouTube search bar and you'll get to my homepage with playlists. I also have 32 hours of pulmonary and sleep medicine CME through a website that we started called Pulmonary and Sleep Academy. CME credit is available for nurses, respiratory therapists, advanced practitioners, and physicians. Check out the site. Homepage of that site actually has some free content as well. This is a last parting thought in the middle of all of this craziness with the pandemic. This is a picture I took last year in 2019 when I was visiting my daughter in Australia. In the outback is the national monument called Uluru or Ayers Rock. That's a spiritual centerpiece of all of Australia.